brachial plexus is a complex network and collection of nerves that are going to supply the upper limb. Now, as it's a very complicated network, it's often easiest to begin with a simple diagrammatic illustration of this network. And there's a saying that I like that helps me remember the order of the contents, and that is, real truckers drink cold beer. Now, obviously this would not be while driving, but you get the idea that this is a simple mnemonic that would help you understand the order and organization of the brachial plexus. So this stands for roots, trunks, divisions, cords, and branches. So if you remember this saying or another one like it, it will help you remember the organization and the distribution of the contents of the brachial plexus from medial to lateral as we progress towards the periphery of the upper limb. Now, the first thing to go over are the vertebral levels that the brachial plexus arises from. And these are going to be from the vertebral levels of C5 down to T1. And if we were to look at the model set, we would see that the vertebrae are going to be numbered from superior to inferior, and they will end at C7. And then T1 will be located inferior to C7. So these are going to be the vertebral levels that correlate to the first components of the brachial plexus, which are going to be the roots. And what we're going to see is that the two superiormost roots, which are going to be from C5 and C6, are going to merge. Then C7 will continue on its own, while C8 and T1 join together as well. Now, the roots are going to arise from these different vertebral levels, and after the junction of C5 and C6, it's going to continue on as a trunk. C7 will similarly continue on as a trunk, and then C8 and T1 would also continue on. Now, the three trunks are going to be named according to their respective orientation. So we would see that there's going to be a superior trunk, a middle trunk, and an inferior trunk of the brachial plexus. Now, each of these trunks is going to split into an anterior and a posterior division. And what's going to happen are the three posterior divisions are going to merge, and then they're going to form into a cord. Now, the two anterior divisions from the superior and middle trunk are going to merge, and they will form a cord, while the inferior's anterior division is going to remain by itself and form a cord on its own. So now we end up with three trunks that form into three cords through the six divisions of the anterior and posterior divisions of the trunks. And what we're going to see is that these cords are going to be named in relationship to a vessel running through this part of the body, and that is going to be the axillary artery. So what we'll see is that the cords are going to have a distinct relationship to that axillary artery, and their names will correlate respondingly. So this will be the lateral cord of the brachial plexus, this will be the medial cord of the brachial plexus, and tucked behind from all of the posterior contributions of the posterior divisions, we're going to have the posterior cord of the brachial plexus. Now remember that these cords are going to be named due to their anatomical relationship with the axillary artery. Now lastly, we're going to get the branches of the brachial plexus, and we're going to spend more time looking at the branches of the brachial plexus independently, as they each have a distinct path and target structure that they'll be going to. The brachial plexus is a network of nerves that supply or innervate the upper limb. The brachial plexus is going to arise from the cervical enlargement of our spinal cord and then emerge laterally at the base of our neck. To help you remember the organization and the structures involved with the brachial plexus, remember the mnemonic, real truckers drink cold beer, which will help you remember that the brachial plexus is formed by roots, trunks, divisions, cords, and branches. For now, we're going to focus on the first four of these organizational levels, from roots down to cords. Before we begin, though, I want to take a closer look and recall that the vertebral levels are numbered from superior to inferior, and the number gets larger the lower down you get within that region. So the first thoracic vertebra would be located superior to T2, which would then descend all the way to T12. In the cervical region, we have 7 cervical vertebrae, so 7 is the last, and then 5 and 6 would stack up accordingly. The roots of the brachial plexus are going to originate from the spinal nerves of C5 down to T1. Now recall that the corresponding spinal nerves are going to emerge superior to the corresponding vertebral level within the cervical region. Now we're going to have 8 cervical spinal nerves, though we only had 7 cervical vertebrae. So what we're going to see is that C5 emerges superior to the corresponding vertebra, the spinal nerve C6 arises superior to the corresponding vertebra, as does C7. Now when we get to C8, this is going to emerge inferior to C7, but superior to T1. And what that does is it now changes the numbering system so that from T1 down, the corresponding spinal nerve will emerge inferior to the corresponding vertebral level. The trunks of the brachial plexus are going to be formed by the junction of the different roots. So what we're going to see is that the superior trunk is formed by the junction of the C5 and C6 anterior rami. The middle trunk is formed by the C7 anterior or ventral rami, while the inferior trunk is formed by C8 and T1's anterior rami. So the ventral or anterior rami are going to supply the structures in the upper limb. The dorsal or posterior rami will go to structures within our neck and back. Each trunk is going to divide into an anterior and posterior division. So what we're going to see is that the superior trunk splits, as does the middle, and the inferior does as well. The 3 posterior divisions are all going to form together as a cord. The 2 most superior anterior divisions are going to form a cord, and the last anterior division remains on its own to form its own cord. The cords of the brachial plexus are going to be named due to their anatomical relationships to the axillary artery. So what we end up having is a cord positioned posterior to the axillary artery, which was formed by the 3 posterior divisions from the 3 trunks. The lateral cord is going to be formed by the 2 anterior divisions, and then it will course lateral to the axillary artery. And lastly, the medial cord is now positioned closer towards the rest of the body, medial to the axillary artery, and formed on its own from the anterior division from the inferior trunk. The cords are then going to wrap around the axillary artery and split into the final components of the brachial plexus known as branches. The branches of the brachial plexus are the actual terminal ends that are going to reach the destination structures. These can be classified as either arising above the clavicle as supraclavicular branches, which will arise from the roots and trunks of the brachial plexus, or as infraclavicular, meaning that they arise from the various cords of the brachial plexus. what we're going to be looking at are the 5 terminal branches, which are going to be the terminal ends of the cords themselves. Now, before we look at the names of these 5 terminal branches, I want to reiterate that the cords of the brachial plexus were named according to their relationship to the axillary artery. So as we descend down through the axilla, we're going to see that the cords are going to wrap around the axillary artery, and that these terminal branches are going to have a distinct appearance in relationship to that same vessel. From an anterior perspective, it's quite common to hear of the terminal branches being referred to as having an M-like appearance. And what this means is that we're going to have branches that are going to originate from the lateral cord, joining with those that originate from the medial cord, and forming a distinctive M type of pattern positioned anterior to the axillary artery. Now, the lateral cord is going to be positioned further away from the midline of the trunk, and this is going to give rise to 2 terminal branches. Directly, the lateral cord is going to give rise to the most lateral of these M-shaped branches, and that is the musculocutaneous nerve. The musculocutaneous nerve is going to course more laterally and will target the structures in the anterior compartment of the arm, and then terminate by innervating some of the skin in our forearm. The middle component to the M is going to have contributions from both the lateral cord and the medial cord, and this is the median nerve. Now, the median nerve is going to course down through the arm, but not actually target any structures within the arm. It's going to be in very close proximity to the brachial artery, and then we'll enter the cubital fossa near our elbow. At this point, this nerve, the median nerve, is going to reach target structures in our forearm and our hand. The last of the branches that is going to be positioned anterior to the axillary artery is the ulnar nerve. Now, the ulnar nerve is going to arise from the medial cord of the brachial plexus and course medial to the brachial artery. The ulnar nerve is then going to course down through the arm, again, like the median nerve, not targeting any structures in this region, and then pass posterior to the elbow to reach its target structures in the forearm and hand. Arising from the posterior cord of the brachial plexus, we're going to have 2 different branches. One of them will target structures within the armpit, and the other will course down in the posterior aspect of the arm and forearm. To better see these, we'll take a posterior view of this region. And what we're going to see is that these 2 branches both arose from the posterior cord. The axillary nerve, which will arise through a square-shaped opening known as the quadrangular space, and target structures within our shoulder and armpit. And the radial nerve, which will continue to course inferiorly along the posterior aspect of the arm to then reach structures in the posterior forearm and a little bit of skin in the back of our hand. On the anterior aspect of the thorax, we're going to have 2 pectoral muscles, the larger, more superficially located pectoralis major, and the smaller, deeper-oriented pectoralis minor. Now, I've cut a window through the pectoralis major here on the left-hand side so we can see some of the underlying structures. I've also cut through the clavicle so that we can again see the underlying structures here in the axilla. Now, the pectoralis major is a large adductor of the upper limb. It's also going to help with shoulder flexion and medial rotation of the upper limb, while the pectoralis minor is going to help stabilize the shoulder by protracting the scapula or helping to pull it forward. So these are 2 important muscles for upper limb movements, and they're going to have nerves that supply them known as pectoral nerves. Now, the pectoral nerves are going to be named according to which cord they arise off of from the brachial plexus. And this is something that's quite important and can be a little bit difficult to understand the first time you're learning these nerves. The lateral cord, recall, was named due to its orientation being lateral to the axillary artery. Arising from the lateral cord, we have the lateral pectoral nerve. Now, the lateral pectoral nerve is going to supply motor innervation to a component of the pectoralis major, but we can see that it is actually closer to the midline of the body and slightly more medial in its orientation than its counterpart, which would be the medial pectoral nerve, which we can see here piercing through pectoralis minor. So recall, again, that the pectoral nerves are going to be named according to which cord of the brachial plexus they arise off of, and not their anatomical medial or lateral orientation when they hit the muscles themselves. So again, if we go to the cords of the brachial plexus, we see that the medial cord is oriented medial to the axillary artery, and it gives rise to the medial pectoral nerve. Now, there's going to be a small communicating branch in a lot of individuals that will, as its name implies, allow for communication between these 2 branches. So there's a decent amount of overlap to ensure that the pectoralis major receives motor innervation. Now, the pec minor is going to be innervated by the medial pectoral nerve along its path piercing through this muscle. As it continues, it's then going to hit the deep side of pectoralis major, again in a slightly more lateral orientation than what we would see from the lateral pectoral nerve. So both medial and lateral pectoral nerves are going to supply the pectoralis major, and again, they arise off of their respective cords of the brachial plexus for which they are named. One of perhaps the most interesting muscles in the body is the serratus anterior muscle. Now, the reason I really like this muscle is because, as its name implies, it has a jagged or serrated appearance. It's going to be arising from the medial border of the scapula and then inserting on the lateral surface of our first 9 ribs. Now, this broad, flat muscle is really quite unique in where it's oriented and some of the clinical correlates related to this muscle. So, as we can see, it's arising from a deep location in our back on the deep medial aspect of the scapula. It then courses laterally around the thorax and is going to use these finger-like attachments to grab on the lateral aspects of our thoracic cage. Now, the role of this muscle is to help stabilize the shoulder. So, when the muscle contracts, it's going to help with protracting or pulling our entire scapula forward and assist slightly with rotation of the scapula as well. But it's a really important stabilizer. So if there's damage to this muscle, we get a condition known as winged scapula, where we're unable to hold the scapula in place against resistance. So to test this, a clinician might ask a patient to just lean against the wall with their hands in front of them, braced out to hold their weight. And as they lean forward, you can actually see the scapula fan out or wing away from the thoracic cage, creating a small depression here in the back. So without the serratus anterior's function, the scapula will wing away. Now, the nerve that's responsible for supplying this important muscle is the long thoracic nerve. And the long thoracic nerve is going to arise from the roots of our brachial plexus, from C5, C6, and C7. So you could theoretically have a herniated disc in your neck or damage in the neck that might lead to this condition. But we're far more worried about damage to the phrenic nerve in a neck injury than we would be to the long thoracic nerve. What's likely going to happen to damage the long thoracic nerve would be a superficial wound or a penetrating trauma. Now, I had an anatomy instructor who would always discuss knife fights. So theoretically, if someone were in a knife fight and were to slash their opponent here under the armpit, they might hit the long thoracic nerve and therefore paralyze the serratus anterior muscle. I don't know how often that occurs, but a car accident with trauma from a lateral blow from one vehicle hitting the other is far more likely. Additionally, you may see boxers that would hit their opponent right underneath the armpit of their person they're fighting to damage or desensitize this nerve. Because if you hit the long thoracic nerve enough, the serratus anterior is not going to work as well. Now, the reason this works is it's a superficially innervated muscle. The majority of the muscles in our body receive their motor innervation from the deep surface. This helps protect the nerves. So because of the development of this muscle wrapping around the side of our body, the nerve becomes exposed and thus more prone to damage. Now, a mnemonic that I find useful to help you just remember that the long thoracic nerve is going to innervate the serratus anterior muscle is SALT, S-A-L-T. This will stand for serratus anterior long thoracic nerve. It also works for the blood supply, which is the lateral thoracic artery. Now, you can remember these two because long has an N in it, so that is the name of the nerve. And lateral has an A in it, so that is the name of the artery. So the serratus anterior is innervated by the long thoracic nerve and gets its blood supply from the lateral thoracic artery. The arm is the region of the upper limb located between the shoulder and the elbow. It can be subdivided into two different compartments or groups of muscles. There's an anterior compartment that is located anterior to the humerus, and a posterior compartment that will be located posterior to the humerus. The anterior compartment of the arm is going to have one nerve that will innervate all of the muscles within that compartment, and that is the musculocutaneous nerve. Similarly, the posterior compartment of the arm will have one nerve that will innervate the muscles within this compartment, and that is the radial nerve. The anterior compartment is going to be innervated by the musculocutaneous nerve. Recall that the musculocutaneous nerve arose from the lateral cord of the brachial plexus. This nerve is going to course laterally through the axilla and pierce the coracobrachialis muscle, one of the muscles within the anterior compartment of the arm. It's then going to course inferiorly and travel between the two other muscles within this compartment, the more anteriorly located biceps brachii and more posteriorly or deeply located brachialis muscle. So this one nerve is going to be responsible for innervating all three of the muscles within this compartment. The posterior compartment of the arm is going to be innervated by the radial nerve, and the radial nerve arose from the posterior cord of the brachial plexus. Recall that the posterior cord was located deep to the axillary artery. Now, the posterior cord is going to divide into two branches, an axillary nerve, which will remain within the axilla and target two different muscles, the deltoid and the teres minor. The radial nerve is going to be located more inferiorly and pass inferior to the teres major muscle and then target the posterior compartment of the arm, which contains the triceps brachii. Recall that the triceps was so named because it has three heads. The radial nerve is going to travel deep to the triceps and then innervate a muscle that also originates within the posterior compartment of the arm, though it connects in the forearm to its distal attachment. And this is the brachioradialis muscle. And although it's an elbow flexor, it originates posteriorly and is innervated by the radial nerve, as are the triceps. The other nerves within this region are going to bypass the structures within the arm and not target any within this region. And those are going to be the median nerve, which arose from the lateral cord and medial cord of the brachial plexus, and the ulnar nerve, which is going to arise from the medial cord of the brachial plexus. So both the median and ulnar nerves do not target any structures within the arm, but they need to bypass the arm to reach the target structures in the forearm. The forearm is the region of the upper limb located between the elbow and the wrist. Recall that there are two different bones within the forearm, a more laterally located radius and a more medially located ulna. These two bones are going to subdivide the forearm into two compartments, an anterior compartment located anterior to the two forearm bones, and a posterior compartment which will be located posterior to the two bones in the forearm. Each compartment is going to be innervated by different nerves, similar to the organization we saw with the arm. Now, however, the anterior compartment of the forearm is going to be innervated by two different nerves. The majority of the muscles within this region will be innervated by the median nerve, while the ulnar nerve is going to innervate 1.5 muscles in the forearm. The posterior compartment of the forearm is going to be innervated by one nerve, the radial nerve. And recall that the posterior compartment of the arm was also innervated by the same radial nerve. Therefore, the radial nerve is going to be responsible for innervating both the posterior compartment of the arm and the posterior compartment of the forearm. Thus, if you lost the radial nerve, you would lose all extension both at the elbow and the wrist. Let's take a closer look now at the two nerves traveling into the anterior compartment of the arm to innervate those muscles. These were the median and ulnar nerves. Recall that in the arm, the median nerve and the ulnar nerve did not innervate any target structures. However, they're going to descend through the arm to then reach the structures within the forearm. The median nerve is going to be located more anteriorly and enter a space known as the cubital fossa, in close relationship to the tendon of the biceps brachii muscle. The median nerve is then going to pass down through the forearm deep to some of the forearm flexors to enter the wrist, at the point known as the carpal tunnel. The median nerve is going to travel in the anterior compartment of the forearm and then assist in wrist flexion, as well as lateral deviation of the wrist. Now, the ulnar nerve is going to pass posteriorly at the elbow behind or posterior to the medial epicondyle, which is where all of these forearm flexors originated. Here, it's going to travel deep to one muscle, which is the flexor carpi ulnaris muscle. It is then going to travel between the flexor carpi ulnaris and the deep flexor of the forearm, the flexor digitorum profundus, which it innervates half of the tendons for this muscle. So the ulnar nerve is going to innervate 1.5 muscles here in the forearm. It's going to be the flexor carpi ulnaris and half of the flexor digitorum profundus. The posterior compartment of the forearm is a little bit more straightforward. As I mentioned, there's only one nerve here in the posterior compartment, which is the radial nerve. Now, how it gets to its target structures is it actually passes laterally around the elbow and then anterior to the lateral epicondyle, just immediately deep to the brachioradialis muscle. Recall that the brachioradialis arose in the posterior compartment, but is an elbow flexor and innervated by the radial nerve. It is then going to travel deeply and pierce a muscle known as the supinator, and then will innervate all of the different extensors of our forearm, which arise in the lateral compartment, or the lateral epicondyle of the humerus, to then be located within the posterior compartment of the forearm. The hand is going to receive its motor innervation from two different nerves, the same two nerves that innervated the anterior compartment of the forearm. These are the median and ulnar nerves. Within the hand, they're going to target different regions. The thenar muscles, the muscles that go to the thumb, are going to be innervated by the recurrent branch of the median nerve. The lumbricals are four intrinsic muscles located deep in the palm of our hand, two of which will be innervated by the median nerve, and the other two will be innervated by the ulnar nerve. The remaining intrinsic muscles of the hand will all be innervated by the ulnar nerve. So the dominant motor distribution to the hand is by the ulnar nerve, which is actually going to target 15 small muscles within this region. The median nerve is going to enter the palm of the hand through a space known as the carpal tunnel, and the carpal tunnel is going to allow for passage of 9 tendons from my forearm to enter the hand to affect movement of the thumb as well as movement of the 4 other digits. Now the median nerve can become entrapped within the carpal tunnel in a common condition known as carpal tunnel syndrome, which would then lead to weakness of the 5 muscles that the median nerve innervates. One branch in particular is called the recurrent branch of the median nerve, meaning that it turns back on itself and goes up towards its origin point, or it is recurrent. This branch is going to target the thenar muscles, and often a surgeon would call this the $1 million nerve, because if in surgery they came in to repair carpal tunnel syndrome and accidentally cut the recurrent branch, they'd be facing at least $1 million lawsuit because that patient would then lose function to the thenar muscles. Now, the radial nerve targeted the posterior compartment of the forearm, and it's going to send a superficial branch which will innervate skin over a region known as the anatomical snuff box. But the radial nerve only provides cutaneous innervation in the hand, and does not provide motor innervation to any of the intrinsic muscles within the hand.
Now how about we have a look at the interscalene triangle block. Okay, so why would we maybe want to do this? What could be some of the essentials about this, right? Well, indications could be, for instance, the patient has to undergo shoulder and upper arm surgery. Okay, so in that case, the transducer position will be as indicated here. That is transversely on the lower neck, about 3 to 4 centimeters superior to the clavicle, over the EJV. Okay, the EJV, the external jugular vein, you can see here, crossing straight down over the sternocleidomastoid. Okay, the goal with the interscalene triangle block will then be to inject a local anesthetic and manage to spread it around the superior and the middle trunks of the brachial plexus and between the anterior and middle scalene muscles. Okay, so this is then performed as an ultrasound guided technique. If we have a look at the era here, we look right in there, we can see very nicely our brachial plexus, and just as it should, it is popping right out between the anterior and middle scalene muscles. So the anterior scalene muscle is right here, and the middle scalene muscle is right here, and our brachial plexus, or the trunks of the brachial plexus, are exiting between these two muscles. You can see the probe is positioned here transversely on the patient's neck. You can slide this, of course, appropriately until you have the best view. That can actually really be quite tricky. If we have a look at the labels here, we are sectioning through the sternocleidomastoid. Actually, zoom out a little bit here that we can appreciate this better. So in this image, we have a little bit of the sternocleidomastoid present as well. That means the probe was actually a little bit closer here where the SEM is. Okay, so the internal jugular vein is right there, and the carotid artery, or actually in that case the common carotid artery, because it's well before it has or it undergoes the bifurcation to the internal external, will be right below it on the ultrasound image. If we then have a look over here, here are 3 trunks, right? These are the superior trunk and the middle trunk and the inferior trunk of your brachial plexus, okay? And down here would be your middle scalene muscle, so the anterior scalene muscle is going to be anterior to it somewhere about here. Actually, no, it's going to be right about here, yeah? So the anterior scalene will be here, and the middle scalene here, and so you can see the 3 trunks coming right out there. So, look in here, one more time. You see where the pink dashed lines are. This is where your anterior scalene is, and the middle scalene, and the trunks of the brachial plexus exiting between these 2 muscles.